Pietrzak?
My name is Dr. Cakic. Everybody knows me as a Chuck. I'm a specialist orthopedic surgeon who decided about 15 years ago to subspecialize in the hips only. And following my fellowship that I did with Professor Weber, which I'm seeing as a pioneer and doyen of hip surgery in South Africa, I learned many ways of dealing with the hip and hip complications. And in my evolution as a hip surgeon, I came across a hip arthroscopy, which going away from the replacement. And at the same time, I came across of idea of, as a preservation surgeon that I see myself, using the more minimally invasive procedure, which is anterior approach. And that is my approach that I use in, I would say, about 90 to 95% of the time in my patients. However, I believe that if one wants to be a subspecialist, has to have a knowledge and ability to do any approach to the hip and decide which approach is the best for that particular patient. So that's why I work with Dr. Pietrzak, because he is far better in posterior approach to the joint than myself, and we're sharing our experiences for the benefit of patients.
I'm Dr Pietrzak. I'm an orthopedic surgeon who works at the Joburg General Hospital, which is a government hospital in Johannesburg. I've been experienced in doing anterolateral total hip replacements, and then in a year's fellowship in the United Kingdom, I was introduced to the posterior surgical approach, which is currently my standard approach. However, I am working and learning from Dr. Cakic because I certainly do have an interest in the direct anterior approach, which is a minimally invasive surgical approach in between the muscles and sparing both nervous planes.
Why do you prefer the anterior approach? Why did you go into the anterior approach? It is an old, I think they started with it initially a long time ago, I don't know how many years ago, and then they moved more to the lateral and posterior approach, and now it's become more popular again, but it is very tricky. So why did you choose that?
You're absolutely right. The first approach that was ever used in a hip pathology was done by Dr. Pietrzak in 1843. And he used, again, like similar what we talk about in hip arthroscopy in children, because of sepsis and because of looking into the joint in a way how you can actually do something in a joint without killing the patient. And because at that time there was no antibiotics, there was no anesthetics and things like that, and that was showing best survival rate, if you will. So this was the first approach that ever been done to the joint. And following that, Hoyte's approach in Germany, there was a development, Peterson's approach, and so many different way of cutting the surroundings around the joint. And then we have basically groups of anterior, lateral, and posterior, depends how you're looking into the joint. So why did I decide to turn, which my bread and butter in the past was a lateral approach and so-called Hardage approach, was purely because my mind was changed towards preservation. Okay. And being exposed to the hip arthroscopy and being exposed to the saving of joint as much as possible, I start doing the approaches, starting with the posterior, starting with the lateral approach to make it as smaller and smaller and smaller, to try to do the less invasive and more rehabilitatable, if you will. And then we did the same with the posterior approach. And eventually you realize that size of the cut is actually not definition of minimal invasive. What actually is important, what you do underneath the skin. In anterior anatomical structure of the hip, we have an interval where we can go between the muscles and we can approach the joint without doing a damage to the musculoskeletal system, because that's why it's called musculoskeletal. The muscle is an engine, can't work without a chassis, which is skeleton, and vice versa. In 2004 and 5, I went around the world again, and I was learning different way how to do the anterior approaches. I went through the 5 different surgical techniques in different places, because it's amazing how the brain works, that the different people in different places independently start thinking about the same thing. And I saw that with this arthroscopy, I saw that with the anterior approach. And in my hands, the AMIS technique that I'm using with the table will end up being the most reproducible, if you will, so that I can do it with every single patient. But however, it's not for everybody.
Okay.
So that's why I'm saying again, it's most important to understand that hip surgeons should know how to choose the best for the patient.
Yes.
So I think if you have a look at the evolution of hip replacements, it's also how we used to measure the outcomes of hip replacements. So when we started, it was all about how long can they last for. So it's the longevity. Can they last for 15 years or 20 years or 25 years? And that's at that stage. That's why I think we wanted these bigger approaches where we could see everything, because we thought that if we can see everything, we can place the components in exactly the correct position. And if the components are anatomical and if the components are perfect, then we believe that the hip is going to last longer because they're more kinematic, there's less forces, there's less stresses going across the hip. But as hip replacements became more popular, and in 2007 it was called the operation of the century, so we started to push the boundaries. And like Dr. Cakic says, he started looking at hip preservation because now younger patients were coming. Patients with bigger demands, wanting to return to sport, wanting more range of movement, who didn't just want to remove pain from the equation, they wanted to go back to sport. And like Dr. Cakic has done, he's got a famous wall where he's got athletes that have returned to win gold medals in karate and gone back to judo and have hang glided and done all these crazy things. So we've started to have a look at needing to give patients satisfaction, meaning they don't want to feel pain, they want to feel happy that they've done the operation. Plus, they wanted to have what we call patient-reported outcome measures, which means we actually ask them, are you happy? Can you climb stairs? Have you returned to sports? Do you have better range of movements? And therefore, we moved away from simply needing to get this thing in perfectly to trying to get this thing in perfectly, plus preserving the muscles, preserving the nerves, and making sure we do as little damage going in as we can. And therefore, we think that by doing less damage, we're now giving the patient the ability to have perfect musculature, perfect movement with doing the less damage. And that's how all the approaches have evolved to starting to get to more minimally invasive and less damage, including the posterior approach. My posterior approach is only a 9-centimeter incision, but I do release muscle. So you do have to release the piriformis, you do have to release these short external rotators, and you do release a small amount of your quadratus femoris, which means that there is some weakness while things are healing.
But you do attach it again.
But we'd have to, but we reattach everything at the end. But the direct and this is where the big difference now comes in, is obviously once you've taken a muscle off or detached a muscle and reattached it, it takes time for that to heal. And that's why the feeling and the belief around the world is that the lateral and the anterolateral and the posterior approaches are less good than the direct anterior approach early on, because there is no muscle detachment with the anterior approach. So patients are up, they're moving, they've got a better gait early on. But as time goes by, and the belief is there that after 2 years, there is no difference.
So then, listening to all of that, what is the better approach? Is it just patient dependent? Or like, why do you have then surgeons that prefer one approach versus a different?
We did recently the study that was sent as a questionnaire to the South African Orthopedic Society, asking the questions about what we're calling a DAA, direct anterior approach. And it is phenomenal results, because it's exactly the same what was published in the United States, that majority of the surgeons would like to know DAA, but they are not doing it because they don't have training. So that's the first point. It's difficult, it is demanding, and it needs certain learning curve. That's the first problem. And that problem starts back in university, because each university in our country has a different philosophy. If you go to Free State, you're going to do only posterior. If you go to Wits, you're going to do only lateral. If you go to the Cape Town, you're going to do either posterior or lateral. Only recently we start actually introducing an anterior approach as a part of the basic training. That's the first point. The second point is that most of the people on the questionnaire who are doing anterior approach are younger surgeons. And the reason why, what it tells you is that somebody who is an established surgeon with 20, 30 years of experience it's very unlikely going to change into
Changes,
something
yeah.
new because it's safe.
Yes.
And that's the way to go.
Yes.
It's crazy to try to change somebody who is good what he's doing.
Exactly.
The
yeah.
point is to introduce it to the young ones
Yeah.
so that the new generation can come in with an extended knowledge. But
Yeah.
it doesn't mean it had to be only DAA, it can be any, it must be all of it.
Okay.
So this is one of the things. The other thing that what Jurek mentioned is about the first 6 to 8 weeks.
Yeah.
Now, I explain to my patients that you're going to have a prosthesis, you're going to have a prosthetic.
Mm.
And I like analogies. So I tell them, you're going to the dentist, and the dentist is going to put a screw in your jaw, but he's going to give you a crown only 3 months later. And there's a reason for it, because they want to wait for that screw to become a part of your jaw. They don't want any pressure on it. Why would we allow the pressure on that prosthesis?
Mm.
So the point of the matter is that, in a way, the pain and inability to do certain things in a posterior lateral approach is a blessing in disguise because they can't.
Mm.
So they protect, indirectly they're protecting the prosthesis. With the anterior approach, people come out of hospital with panada. They can do whatever they feel like. So my job as an anterior surgeon is to put fear of God into those patients,
Yes.
telling them, please, you don't have alarm. Your alarm is switched off. There is no pain. There is nothing in your brain that's going to tell you don't do this or that.
Yes.
You have to do that. You have to protect the prosthesis. So in a way, it's a complex approach to the patient to explain to them, I'm doing something for your benefit.
Yeah.
But if you take a privilege of it, you're going to actually make it worse.
How long does it take for the prosthesis to integrate with the bone?
Most of the prostheses in the market are covered with material that produce effect of bone growing into the prosthesis, and that is taking about 3 months. So in my protocol that we design and what we're using in our hips is that we're not allowing any sporting activities for the patient for the first 3 to 6 months. We do assessments, again going through the physiotherapy, biokinetic and everything, which is essential part of the whole protocol. And then we allow them to start going slowly into the sports only after 3 months, waiting for that biological effect to happen. Now, there are 2 different types of using a hip replacements, and we're talking about total hip replacements, irrespective of approach. If we're using a cement, which is a third component is a grout that keeps the prosthesis in place,
Yeah.
that biological component is taken away.
So
they can start
immediately
with the weight bearing and stuff like that. But it is a philosophy in the world of yes or no cement, because it is a third component, which can go wrong.
Yes.
So we try in the younger people to use uncemented prosthesis,
Okay.
and I always have option in theatre of cement in case if I found that that particular person is not going to do well with uncemented, I have an option of converting it.
What are the complications, the major complications with the anterior approach?
In specifically anterior approach, there is a one nerve which runs in the front of the thigh, which is called the lateral cutaneous femoral nerve. And that damn nerve, in any single person in the world, has a different pathway. It's not one nerve like you know that median nerve is always there and you've got to always find it. That nerve can be spread it in the 5 branches, can be spread it in one, can go anywhere. So you never know when you do the cut, are you going to nick one of those parts of the nerve, which can leave the patient with a feel of numbness in the skin of the thigh in a certain area. And that is one of the biggest criticism of anterior approach. However, I don't see it as a complication. I'm seeing it as a side effect, because there is no person on the face of the earth that had a knee replacement that doesn't have a sensory loss, because all the nerves are running across the knee and you're doing a longitudinal cut.
Yeah.
And nobody comments about it.
Yeah.
There is no person in the world who had a Caesar that cannot say that has a normal feeling above and below the skull, because all the nerves are going that way.
Yeah.
It's not a complication, it's a side effect. So the way how you see it, and how you're percepting that problem, that's how you're going to see it. So if you tell the patients about it, they don't even mention to you anymore.
Yes.
Again, it's about communication.
Yes.
What you expect from that surgeon.
Dr. Eric, what's the complications with the posterior approach?
So
I can, say from my side, from a rear point of view, I think if we don't get the patient functioning properly and doing their rehab, they do have loss of muscle strength in the glute, and they sometimes have that antalgic gait.
With posterior approach, when you think about complications, you've always got to think about, well, in the way in, what are you dismantling, and therefore what are the complications? So I think the biggest complication of the posterior approach is hip dislocations.
Okay.
Because you're actually removing those posterior structures which you're preserving in the direct anterior approach, and therefore things can pop out.
Okay. And is that just in the first couple of months?
So I think that's initially, and then once everything is rehabilitated, then it decreases. And in the literature, the complication rate with regards to dislocation is far higher in posterior approach than it is in the anterior or the lateral approach.
How does a patient decide what to do and where to go to? Is it always good to have a second opinion and then the patient just sort of decides what's going to work for them? If I had to have a hip replacement now, how do I decide?
Yurek's going to go after me with the same question, but my opinion, it's not your choice. Where your decision comes into it is a trust. Now, you need to know who you're going to trust. And you need to have that trust in you that that person who is going to be your surgeon is going to do the best for you. Is that going to be anterior, posterior, lateral, upside down, way forward? Irrelevant.
Okay.
You want to have the best results for you.
Yes.
And that's my answer to your question. The decision that I'm going to make as a surgeon, again, is going to be the best for you as a patient. In my hands, as I said, about 95% of times is an anterior approach. But there is a patients that are not for anterior approach, and I'm telling them straight away, this is not for you. There is psychological component that is extremely important. It is a long-term relationship. Once when I put the hip in, you become my patient for the rest of my life, or yours. Every problem, every complications, everything in the future, it's between us.
So choose your surgeon, not your approach.
I think so.
Okay.
What do you think?
So everything Dr. Cakic just said, I agree 100%. I think for anybody listening out there, I think we've all got to understand that the approach is actually a small part of the whole procedure. You know, the approach is important, and the approach helps you get there. But the surgeon also has to decide what implant he's using, what bearing surface he's using. We've also then got to look at, well, what happens in the outcomes. Patients' expectations actually is the biggest determinant of a patient's outcome. So if a patient has a hip replacement and they think, oh, I'm going to go and start gym 1 week later and I'm going to start lifting 150 kgs and then I'm going to run the comrades within 6 weeks, they're never going to be happy after that replacement, and they're actually looking for trouble. So I have to concur entirely. I personally believe, choose your surgeon, choose someone who cares, choose someone who's ethical and professional and is going to do the best for you. And then also patients have to realize that it doesn't just stop and end with a surgeon. The physiotherapist, the biokineticist, the anaesthetist has a big role. I think you'll hear Dr. Cakic say it all the time, and it's teamwork.
Yeah.
And part of the big team is the surgeon may start off as the manager, the football manager, who dictates things, but the patient plays an important role, and I think it's essential that patients keep up with this rehabilitation. Your hip is there with you for a lifetime.
Yeah.
So you've got to treat it well for a lifetime, and I think it's essential that the physiotherapist is simply a bridge to your biokineticist. The physiotherapist gets and packages your hip to a point where the biokineticist is safe enough to build up and help you build up those other muscles to allow you to go back into your life, because that's why we're doing this whole procedure, is to give you back your life.
I think also that what is important to understand the social background of the patient. I can talk only about what I see in private practice in South Africa. If I'm having an 80-year-old lady that wanted to have a hip because she's in pain, and she's not interested in doing anything except being at home, then you're going to have a different post-operative care than for somebody who is 50 and he wants to go and play golf and cycle and this and that.
Yes.
And I think that one thing that we start breaking it, and I hope I broke that mental block in the people in my practice is that historical thing that hip replacement was for the old people and hip replacement was for the pain relief.
Yeah.
And you are never ever able to do what you were doing it before hip
After you've
replacement.
had it.
And this is a perception in the people in the world.
Yeah.
And this is what people ask me: how long my prosthesis is going to last? Am I going to be able to go for walking? Am I going to be able to play tennis, and so on and so forth? So this is again communication and education. That perception of the hip replacement in 90s and 80s or last centuries are completely different now.
Yeah.
It should be different than perception to the hip replacement. The hip replacement is happening in 10% of population of the world. That's it. Every person who is born has a 10% chances to end up with a joint replacement by age of 65.
I think the last thing I want to just discuss is high impact stuff. Can they go back to running? You mentioned tennis. Can they do those type of sports after hip replacement?
The only study that somebody was asking me to publish something about 3 years ago in a local journal, so I went to the research at that time, and only publication that I found about it was from 91. So this is already 30 years old.
Yeah.
And in that publication, they classified into 3 groups: absolute no, kind of in between, and what you can do. And in that group, interestingly enough, the absolute no is running.
Okay.
For example, yes, you can do is a tennis, but absolute no is a squash. So there are certain limitations because you do have a piece of metal.
Yes.
Now, is that change? You reckon? Correct me if I'm wrong afterwards, but is it a change in the last 30 years? Yes, it is.
Mm.
So officially, as a surgeon, I tell my patients you should not do this and this and this.
Mm.
But I have some people that are in comrades on it. Shall we call them nutcases? You can. Shall we call them the people who enjoy their life? Absolutely.
Mm.
They know, I told them, if you do that, you have these chances that go wrong.
Mm.
If you're prepared to take those chances, be my guest, and when you get your gold medal, send me a picture so I can put you on a wall.
Just on that point, I think for anybody watching this, there's different risks. So when you say go back to sport, there's the risk that you're actually going to wear out your head that's rubbing on your acetabular. So I think what's definitely happened over the last 30 years, and in fact Dr. Cakic just done his PhD on this, is that the bearing surface has changed. So the head rubbing on the cup. So that has changed and that has certainly improved. The next big worry that you worry about is that by running on this, you're actually going to loosen that prosthesis and the bone that's grown onto the prosthesis. And that's why, theoretically, what we want is in younger patients, we want to use an uncemented prosthesis because then the bone has grown onto those prosthesis, and theoretically it's a lifetime integration. And then of course the next thing that any surgeon is petrified of is dislocation. So if you go back to judo or Brazilian jiu-jitsu or something like that, you're going to get into a position where you're going to pop the hip out. And then the last thing of course is you're worried about periprosthetic fractures, where you're going to do something high impact and you're going to fracture. So I think things have evolved and the materials that we're using have improved and those have changed. But have we got the perfect implant? No, we certainly don't. But I think I like Dr. Cakic's philosophy is that do the best operation for that patient to allow them to make those decisions. Mm. And then the last thing is why I like the direct anterior approach is that as a revision surgeon, and that's really my passion, is that the revision for anything that's gone wrong. So if you wear that prosthesis out and you've had a direct anterior approach, the revision is far easier because you've actually got a native, beautiful hip still there because you haven't released any muscles, and it's essentially a muscle-sparing surgical procedure.
Okay, thank you so much. I really appreciate you guys taking the time.
My pleasure.
Thank you very much.